me for this session is to give an introduction on the latest guidelines for management of diabetes dyslipidemia. So I'm going to focus my talk on two parts. One is focus on LDL cholesterol, the current guidelines evidence on the cholesterol management. And then I will focus on other lipoprotein fractions of dyslipidemia. Talking about dyslipidemia in type 2 diabetes, it's really three parts. One is this elevation of VLDL and triglyceride, and elevation of small and dense LDL, and then the reduction or decreased level of HDL. All of them were shown to be risk factors for cardiovascular disease in type 2 diabetes population in the epidemiology studies. And also there's evidence from basic research that dyslipidemia, hypoglycemia, and insulin resistance, which is the characteristic of type 2 diabetes, altogether resulting a spectrum of physiological changes, which have an impact on the physiological, on the pathophysiological changes of arterial wall, resulting in atherosclerotic lesion development. And those including the formation of atherosclerogenic low density lipoproteins, advanced glycation end products, and also the activation of pro-inflammation signaling pathways. And so far, the lipid management is an integral part of diabetes management, together with glucose management, blood pressure management, weight control, and then also in addition to the lifestyle modifications. So far, the strongest evidence are coming from the starting therapies in reducing the low density cholesterol. As has been shown from this meta-analysis, the reduction of LDL cholesterol resulting improvement of major cardiovascular outcomes, as well as all-cause mortality. This is also true in primary prevention and also in the secondary prevention of cardiovascular disease and deaths in type 2 diabetes population. In addition, aiding this cholesterol absorbing inhibitants, ezetimibe, to the starting therapy, also showing benefit in further reducing the cardiovascular outcomes in type 2 diabetes population. Recently, the PCSK9, which is more potent LDL cholesterol decreasing agents, were also shown in the general population with a cardiovascular high risk, can improve the cardiovascular outcomes on top of starting therapies. In this trial with another PCSK9 inhibitors, the researchers had did a subgroup analysis or sensitivity analysis by stratifying the study subject into those with type 2 diabetes and those without. You can perceive from this first plot that the effect size on patients with diabetes in terms of cardiovascular disease risk reduction is the same as in other subgroups. So indicating that on top of statin therapies, aiding PCSK9 in type 2 diabetes population also can further reduce cardiovascular risk. So based on those clinical evidence, the ADA has recommended the statin therapies for the primary prevention of cardiovascular disease and death in patients with type 2 diabetes, and also on the secondary prevention of cardiovascular disease in type 2 diabetes. It's also stated that based on those evidence, if statin therapy cannot achieve optimal cholesterol control, you can aid either ezetimibe or, in the case of a secondary prevention, PCSK9 to further reducing the LDL cholesterol levels in order to improve the prevention of cardiovascular disease in those with higher risk of developing those conditions. This was also reflected in the guideline of Chinese Diabetes Society. It's recommended starting as a first-line therapy for managing higher cholesterol levels, and if needed, other medications such as ezetimibe or PCSK9 inhibitor can be aided to further improve the level of cholesterol control. So how about other lipoprotein fractions or targets outside the LDL cholesterol? From the clinical trials aiming at reducing the LDL cholesterol levels, there's still a residual risk that cannot be addressed by simply reducing the LDL cholesterol levels, such as in IMPROVE IT study, which is a combination of simvastatin and ezetimibe, and the FOURNIER study is a combination of LDL statins with ivocumab, which is a PCSK9 inhibitor. And also there are many epidemiology studies showing that the elevation level of triglyceride is associated with ASCVD. And also there are many mechanistic studies or basic research indicating that triglyceride might play a role in the atherosclerotic process that leading to the cardiovascular disease. But unfortunately, using the niacin either in combination with statins or uses alone didn't show a clear benefit in further improving the cardiovascular outcomes. The same is true for those agents that can increase the level of HDL cholesterol, because in the epidemiology studies, the elevation of HDL cholesterol is a protecting factor for the cardiovascular disease in both general population and also in type 2 diabetes. From the previous clinical studies, it didn't show that statin plus fenofibrate or fibrate study can further improve the cardiovascular outcomes, questioning the role of triglyceride lower therapy in the role of preventing cardiovascular disease on top of statin therapies. And there are dedicated trials to try to address the role of fibrates in reducing triglyceride levels on top of statin therapies, such as in the Accord study, the researchers didn't show that on top of a statin standard care, aiding the fenofibrate have further improved the cardiovascular outcomes. But in the subgroup analysis, the researchers have identified there's a trend in the subgroup with they called diabetic dyslipidemia, which characterized by increased level of triglyceride and decreased level of HDL. But unfortunately, a dedicated trial tried to prove this hypothesis that this diabetic dyslipidemia is a cause for cardiovascular disease in type 2 diabetes population. And this COVA trial has recently been adjourned because of a lack of efficacy. In this trial, they use pemafibrates, another agents that can reduce the level of triglyceride. And this study didn't show that aiding these agents to reducing the level of triglyceride on top of statin therapy can further reduce the outcomes of cardiovascular disease. Therefore, the ADA didn't recommend either improve the endothelin function and also have anti-inflammatory actions and also have an anti-thrombotic effect. There's also study indicating that omega-3 fatty acid can have anti-arrhythmic actions. In the reduced trials, researchers randomized patients receiving statin therapies to the placebo and then this omega-3. And the study did show that a combination of omega-3 fatty acid with statin have a beneficial effect in reducing the cardiovascular disease in the population with higher triglyceride levels. But another trial using the same strategy, the STRENGTH trial, didn't show that among statin-treated patients, the aiding of these omega-3 agents could further reduce risk of major cardiovascular events. And if we look at the difference between these two trials, and there's the effect size of omega-3 in the two trials are very similar. But what make the difference in these two trials is that they use the different comparator. In one trial, which showing the benefit effect of a combination therapy, they use minimal oil as a comparator. Actually, the minimal oil have a detrimental effect in terms of cardiovascular outcomes.
As